Hello, everyone. Happy New Year. Welcome to our first CEMA Africa seminar in 2026, and we appreciate you taking the time to join us for this important session. I am Annie Njanja, a communication specialist at CEMA, and I'll be moderating today's session. And before we begin, I want to recognize the presence of our co-director, Professor Thombi Mwangi, and of course, all of you who've joined us for this important session. Today, we will be discussing a major shift in Kenya's health landscape. So after the 2025 US policy pivot toward America First and others, including European donors, diverted health aid toward their own domestic priorities, our health sector, because of that, has faced unprecedented withdrawal of external support. In Kenya, this withdrawal has affected various programs, including HIV treatment, access to vaccines and other commodities, and primary healthcare delivery. To analyze how our health budget allocation looked like over the years and the resulting funding disruptions and gaps, we are joined by Dr. David Khaoya, a leading health economist and health financing expert and a senior research fellow at CEMA, who has been at the forefront of tracking how these global shifts translate into local consequences. But before Dr. Khaoya takes the floor, it is important to note that the analysis shared today are drawn from a CEMA report that will be shared with everyone later. But also, it's important to know that it does not take into account the new agreement and the commitments therein between the US and Kenya. And this, of course, follows the agreement that was signed in December last year. And Dr. Khaoya will explain in detail later. Please use the chat to introduce yourselves, learn more about CEMA, or to post your questions, which Dr. Khaoya will address at the end of the session. Without further delay, Dr. Khaoya, welcome. The floor is yours.
Yeah, thank you very much, Anne, and everybody who has joined. Just confirm that you can hear my voice.
Yes, loud and clear.
Thank you. So participants will allow me to use my slides to share my thoughts around this topic.
Yes, it did him. I think Khaoya still doesn't have access. Okay, awesome. Thank you. Sorry about that.
Yeah. Okay. It's taking time to move. I don't know why, but I'll try to see if, yeah. Okay. Okay. So as Anne has introduced me, my name is Dr. David Khaoya. I work as a senior research fellow at the Center for Epidemiological Modeling and Analysis. And if you want to get more details of what the center does, please feel free to go online. It's focused on epidemiological modeling, but of course, the need to also look at the health of the economy, and that's why we are also looking at the economic aspects of how the impact come into play. So today I will be sharing on behalf of the team at CEMA. On behalf of the team at CEMA that worked on this work, I will be presenting this work, and I want to mention to you also that this is the first phase of the work. The additional analysis is ongoing, and we will be presenting the findings of the additional work much later. And so the focus today is on the immediate impact of external funding withdrawal on the health sector in Kenya. And we will be looking at the financial impact in the immediate term. And later on, we will be looking at how that impacts the health outcomes, outcomes. And later, we will also be looking at how it impacts other sectors, and that we'll be doing it in phase 2. So as a way of introducing this topic, most of us are aware of all the changes in foreign development assistance that we have witnessed, especially in the year 2025. And these changes have a significant impact on health provision, outputs, and outcomes, especially in countries or regions that substantially depend on external assistance. And to be able to understand this better, we basically focus on the US policy shift that actually shifted towards America first, basically trying to indicate that all aid, especially from America, should make America safer, stronger, and prosperous. And through that, of course, there was a stop work order that was issued, basically suspending all funding to
the voice maybe Roba kuna remote up. Wide volume.
Please, guys, stay muted to avoid the interruptions. Thank you.
Yeah, so the shift actually meant that there's a suspension in funding development assistance to countries that rely especially on that type of support. And we also need to recognize the fact that there were some emergency waivers allowing continued HIV treatment access, which of course we were not able to get information in good time to be able to update our report. But we are acknowledging the fact that the funding was not suspended 100% because of these waivers that were allowed to continue. The policy shift has also affected global organizations that actually rely on US government funding. Some of them, the ones I've listed here, the Gavi, WHO, Global Fund, and the bank. And for example, the Global Fund, based on the reductions that have impacted them in 2025, announced a reduction of between 13 and 15% to what they had already committed to countries. And for Kenya, this meant that the country was requested to reprioritize based on the reduced budget. And the shifts have also affected other European countries, especially organizations in Europe that have actually also been affected because of the realignments in priorities, and now they are being requested to buff up the security budgets, and the culprit now here is the foreign assistance. So we have seen agencies that actually fund programs from this type of this region also announcing, giving notice and announcing funding realignments in the coming years. So as a result of all this, of course, one to do is to try and think of what does it mean if these funds are withdrawn, or what does it mean? So for Kenya, the Ministry of Health requested the Center for Epidemiological Modeling and Analysis, where I work, to assist with analytical insights or to actually bring out what it means to have this development assistance withdrawn, and more specifically to the health sector. And like I've said, later on in the second phase, we are working to see how this also affected the other non-health sectors like agriculture and so industry and so on. And so part of what was required is to try and see, based on the insights that we provide using this analysis, to come up with mitigation strategies as to how we can deal with some of the consequences that come with the withdrawal. So to do this, of course, we came up with 3 specific objectives to guide us in analyzing this data, especially the first one being to estimate the size and trends, channels of external funding, and the relative contribution of external funders. And I need to mention here that we had to put it like this because when we started, we were focusing on the US government withdrawals, but then we realized that it's going beyond the US government withdrawal. So this is now expanded to cover all funding withdrawals, external funding withdrawals. The second objective is to determine the diseases, factors of provision, geographical coverage, and services, as well as beneficiaries that are covered by external funding. And finally, we will be estimating the immediate impacts of external funding cuts on service delivery, outputs, equity, access, workforce, and so on, so that we basically understand in the full breadth of what this impact affects us. So to contextualize our discussion, I thought of bringing this diagram or chart here, just to try and contextualize the flow of funds within the system, the healthcare system in Kenya. And this one is only focusing on budget support, which I'll explain shortly. But basically what we are saying is that the national government is responsible for collecting all revenue, and it complements its revenue with the revenues or rather support from external funders, which comes in different forms, either loans or grants. And through that, now they put the funds together and appropriate to the different ministries after netting off what we call consolidated fund service expenses, which are basically servicing the debt, then paying for pension and gratuities, as well as paying for international subscription. So whatever is left is now appropriated to the ministries, of course, after also paying for the for shares that normally go to the counties for distribution, from the budget. So as you can see, I've tried to provide colors just to show like how these funds go through the system and how they end up to the health facilities down there. You will notice that I have deliberately left out the Social Health Authority funds flow because it's basically a reimbursement of what health facilities are providing, but it's funded through this mechanism that we are showing. But that's a subject for discussion, which we are finalizing on a proper funding flow. So in terms of how we did the assessment, of course, we started by tracking the budgets. Of course, what we have concluded is that we track the budget, and then we know exactly where we are affected. Because once you track the budget, you'll know where the money is going. But now to do that, we had to track the government budget. And the government budget gave us 2 types of data. It gave us what the government is committing or budgeting for its programs, especially within the health sector, and also what the government is receiving as on-budget support. This is important because it forms a big component also of what is coming in to support the programs within the government. But to complement that, we also used the country operational plans, especially from the US government agency, the defunct USAID, which was very important because it provided very useful information for us to know exactly which programs are supported and the type of inputs that the US government supports. We also complemented this with the other donors' reports. There are other donors' reports we had to rely on to be able to get the full picture, especially for those who support off budget. And I'll be explaining what that means shortly. So the other piece of information we relied on is what we call the commodity requirements quantification reports, which are basically reports by disease programs indicating what their requirements are in terms of like what they require in terms of commodities, especially over a period of 1 year. And then they forecast that for the subsequent years. So this was very important so that we could then know what type of gap we are dealing with when we talk about, for example, commodity, the commodities that are required for purposes of being used within these disease programs. The last piece of information we relied on is the list we got from PEPFAR, which is basically a list of all staff that the PEPFAR was supporting as at a specific period. And because we did not have the values that we only had the list and the numbers and the cadre, we were able to actually liaise with the Ministry of Health to obtain the monetary value of providing those services if the government were to take them up. So we did not really go into using the rates that the donor uses. We used the rates that the government would use if they were to absorb those staff. And so using this data, we estimated the immediate financing or financial impact in terms of a gap, basically focusing on the factors that we identified in the course of our analysis. So let me allow me to hide something. Sorry. Sorry about that. Trying to, something is blocking my view here. So let me push it. Yeah, okay. Yeah. So I've brought in this chart just to be able to show you, for example, the extent of government budget that goes to health sector. And here we were lucky also due to the time we had to bring in the contribution from the counties also, although this is not going to be very useful for the purposes of our discussion today, because it's basically just trying to give the full breadth so that I can now tell you what we will be focusing on. So if you look at this, the ministry, together with the support from partners, has been keeping a record or tracking the budget over time in terms of how much is allocated to the health sector year by year, and both through the Ministry of Health and the money that comes through the subnational level, the counties. And as you can see, we have also put in a line to show the proportion that comprises in terms of the overall revenue, government revenue. And one thing that you notice is that from 2021 onwards, we witness inelasticities in the health budget, meaning that the overall budget is growing, yes, but as the overall budget grows, we do not see commensurate growth in the health budget. And that actually calls for some further discussion to understand which are these sectors that are being prioritized more than the health sector and why. So I think that is an important point to discuss, maybe in a future seminar, so that we can understand why is the government or in general, both national and county, not prioritizing the health over time. And we continue seeing the decline from 2020, 2021 of 11.1% to 9.1%. And this, I just need to mention that this is actually the proportion after netting off the consolidated fund services. And so our focus today is on the blue part, which is basically the part that looks at the Ministry of Health budget. And I will now be disaggregating it so that you understand, like when we talk about the amounts that we see there, which are basically amounts in Kenya shillings, in billion Kenya shillings. So for those colleagues watching from out of the country, if you want to know the dollar equivalent, just divide whatever number you see there by 130. Then you will understand what the dollar equivalent is. And if we do that, we see that on average, like in 2025, 2026, the Kenya government allocated close to $2 billion to the health sector, with maybe almost 50-50 from both the subnational and the national level. I don't know why the slide is not moving. Okay, good. Yeah, so to be able to now understand the actual funding, what we have done is to come up with, sort of analyze the funding landscape for the health sector after focusing only on the funds that come in through the national government, because there was no reason for us to focus on the county government, because most of the external funding comes in through the national government. And so to do that, we have more or less reproduced what we have seen in the past in the previous chart. The last two, the bottom two colors are basically representing the Ministry of Health budget allocation to the health sector. And we have done that since 2019. So you can see clearly whether the figures are increasing or they are stagnant and so on. And so what we have done here is to bring in the budget allocations to the sector that come through other ministries. For example, in this case, we have targeted the Treasury because the Global Fund money comes through the Treasury. And of course, Treasury, the arrangement with the Global Fund is that for the money they give, the government should also provide what we call counterpart funding. So you see the GOK National Treasury also has counterpart funding that comes in, albeit a little fraction, but it's a requirement of the funding agreement. But more importantly is the top green color, which we have brought in to show the funding that comes in what we call off budget, meaning this is money you will not really find in our national budget, but it's money that is coming to the sector, but through what we call off budget. And I'll explain shortly in detail what that means. Okay. So what we've done is to now tease out the full extent of the external funding from all the national budgets that we have seen. We have teased out the external funding, and I think it makes more sense for us to see it in this manner, so which disaggregates it into what is on budget and what is off budget. So on budget is where the government has been given money and it adds together with their own budget and then appropriates it based on what agreements they have. So if there are some donors who will give you funds and you will apply it according to your own priorities. But of course, there are others who will give you funds, you add to your budget, but then they also prescribe where they want their money to go. So we will be seeing some of those in a short while. But then there is also those who are supporting you, but they don't want to give you the money directly. They want to spend the money, they want to have control of the expenditure themselves. So what that means is that you may not sometimes have visibility of what the extent of that support is. And if you are not organized in terms of collecting information, you may not even know what they are supporting. And that has been part of the challenge, where some activities are being implemented within the counties, but maybe the national government has no visibility because it's off budget. But that is being addressed by the government through the new funding agreement arrangement, where they are coming up with a tool to be able to track all support that comes in, whether it's on budget or off budget, the so-called RNet. And I'm sure they will be unveiling it soon for those of you who are interested. But more importantly here is to show also that the bulk of our support has been off budget. If you look at the blue bar, that is the on budget, is smaller compared to the orange part of the bar, which is off budget. And we can also see that by 2024, 2025, the off budget was coming to about 87 billion Kenya shillings, which was far much higher compared to the previous year. So there has been growth over time. But then come 2025, 2026, we see that bar reduces substantially. And that is some of the impact that we are trying to capture, because we see clearly that that must be impacting at some point. And so part of what we want to do is to ask ourselves, where is it impacting? But before we do that, we are asking ourselves, so how does this money come in? Is it loan? Is it grant? And so on. So what we have done is to disaggregate the funds here that come on budget, because it was easier for us to see on budget. The 28 billion, for example, I'm using the outer year, 2025, 26, just to demonstrate, but it's the same story going back all the way to 2019. So what we have done is to extract the 28 billion and then try to disaggregate it into grants and loans. And what is clear from this chart is that loans have actually been the bigger proportion compared to the grants in the many years going back, except in 2025-26, because we had more grants in this year and so on. So one thing that we note at this point is that when we talk about government external debt or debt servicing, we should also be aware that part of that money actually is being utilized in the health sector. So we should not look at it as if it's money used elsewhere. Part of the loan that is being serviced is actually money utilized in the health sector. And so the most preferred type of support will have been grants, but here we cannot be able to get grants 100% and so on. So the next question we ask ourselves is that where does this money come from? Who is giving the government this money? And it became very clear when you look at the years before, and you can see clearly that there are many external funders, some from the UN family, others bilateral, others are multilateral. And what we see before 2025, 2026 is a very big proportion of the blue color, which is actually a representation of the United States government, which has been one of the major funders of the health programs in Kenya. And that funding was withdrawn in 2025, 2026, and that's why you see the bar generally drops to a very small bar. And that has implications, because then the next thing that comes into our mind is that, so what was being funded, now that we know who was funding and the different channels through which they fund, and whether it comes in as loans or grants, so who was funding, what services were being funded. But before we do that, I think it's also important to understand the funding sources that are there in terms of the proportion with diseases. By disease, we see that there are certain diseases which have been consuming the bulk of the money. We were not able to get the finer details in terms of absolute numbers, but we were able to estimate using the data we had. And we see clearly diseases like HIV, TB, malaria, and RAMCA, reproductive health, have been the major diseases that have been consuming the funds, especially from external funders. But we also have other programs like UHC programs, PHC, strengthening, and so on, which have also been funded through external sources. So this gives us an indication that then we need to find out within these diseases that we have identified using this analysis, what exactly have the funders been supporting And that is what we did next. And we identified, by going through the budget, we identified that one of the factors that factor inputs that has been funded by donors is basically commodities. Now, but to make sense out of this, we decided to first get the resource requirements so that we could then estimate the gap, because it's not enough to just say they are funding commodities. We want to know what is the extent of commodities we require and how are they funded. So you can see clearly that the first or rather second column is giving us the resource requirements for each disease, and the next columns are providing like where the funds are coming from, and we've seen the different sources of funds. Here we are only now zeroing down to those that fund specific disease programs, especially commodities in those programs. And what we see is that there's a gap in HIV, TB, malaria, vaccines, and so on. But then there is an excess funding which is coming in to support RAMCA programs. And that also points to the fact that there are, and this is what I alluded to earlier, that you could be getting support from external sources, but the support is coming with a condition that we want you, we are supporting you on this program. So it becomes difficult for government to via such funds. And so part of the recommendation is to see whether the government is able to negotiate for environment, so that if you have a program that is overfunded, then you can be able to redirect excess funds to other programs that are underfunded. And this is clearly what we are seeing. So we have established a gap, although this gap does not take into consideration the excess in the RAMCA, excess funding in the RAMCA program. What we have done is just to add the gap for the other disease programs when it comes to commodities. So this is a commodity gap that was estimated as a result of the funding withdrawal. So you can see the US government column is nil because we did not have figures at the time to say exactly what they were supporting. At the time we were doing the assessment, it was like total withdrawal, but we've realized that there were some waivers. So this gap may be considered to be the upper bound if we net with what the waivers will have come in to reduce the gap. The other factor is basically the human resource. As I mentioned, we received a list of staff by CADA who are supported across the country in different counties. And we see clearly that some counties have quite a number of people supported, staff supported by PEPFAR, and we will see why. And so what we did was to try and convert this into monetary terms so that we could then advise government and say, look, if you are to take up, say, the staff that were previously supported by PEPFAR in Baringo, then you will need 154 million Kenya shillings to support them for 1 year, and so on. So what we did is to go to the cadres and then try to use government compensation rates to understand how much that will cost. One of the challenges we had, of course, was the issue that some of the cadres were not in the government scheme of service. So the supported staff, some of them were not, their cadres were not actually listed in the government cadres or scheme of service. And so working with the colleagues from the ministry, we were able to sort of estimate the equivalent cadre so that we are able to know how to cost that. But more importantly is that there are certain counties here that are really dependent in terms of the number of staff that are covered by donors is quite high. And you can see clearly the likes of Kilifi, Siaya, and so on. And we have also seen here Nairobi County, Nakuru, and most of the counties in Nyanza. And the reason is when we did this assessment, we realized that the reason why they are having such high numbers is basically partly because of the high burden. If you look at then those counties that we have just highlighted, they're basically having a very high HIV burden, and therefore you can then understand why they were having more staff supported. And so the question you should be asking yourself is that what happens now that the support is suspended or is withheld? So we expect to see quite a number of effects or impacts within these regions that have been relying on this stuff. Service delivery will be affected. And more importantly, the health outcomes may also be affected, because if you don't have staff to be able to provide care, then the people who are suffering from this disease will definitely be impacted in one way or another. And then, so having known the diseases that are affected, because we have the budget lines which we have gone through and identified the specific diseases based on the analysis we have, we also wanted to understand the funding landscape within these diseases so that we could understand the extent of impact. And so we have HIV, which basically we have analyzed over time from 2020 to show like what has the funding been and where has it been coming from. We have seen donor funding coming through the National Treasury, especially the Global Fund money that buys commodities, as well as MOH funding, which is basically divided into both donor support and MOH contribution, which is the donor funding normally is to support the agencies that deal with these diseases specifically. And then we have the National Treasury counterpart funding, which is the money that I mentioned earlier that the national government is supposed to put in as their contribution to fulfill, so that they can be able to qualify to get the funding from the funding source. And so what we see is that even with the own budget, we see a decline in external funding. And that's why we said that let's broaden this so that we don't just look at the US government funding, let's look at all external funding. So we see from say 2024-25, we saw a decline in donor funding. But what struck me most was the proportion of the budget that the government is putting in. It also went down, and this was counterintuitive to me because I thought that if the donors support is declining, then the government should come in strongly to fill in to bridge the gap. But of course, I know the way government works sometimes. When you analyze the approved budget, then you realize that certain realignments or adjustments are done in the supplementary budget. So we have just focused on analyzing the approved budget. And the same story repeated with the other diseases. TB, for example, had a similar story. We had this other disease, this is malaria, also had the same story. And so the issue is that we have witnessed a decline in external funding. And in some diseases, we have also witnessed a decline in government contribution. And so just because we may not be seeing many people lying on the road sick now, what we know is that some of these impacts will take time to be seen. So our team at CEMA are trying to look at the epidemiological side of modeling to just understand what does it mean, for example, for patients not getting ARVs, for patients not being treated, for mothers not being treated for malaria and things like that. So part of the assessment in the second phase will basically to bring out those nuances. And then finally, like I mentioned, the overfunding that we witnessed in the RAMCA program, where the new external funders have come in and their money has also been directed towards reproductive health. And so it has led to what we see in the books as overfunding, and yet we have underfunding in other programs. And this is something which I'm sure once I've actually made this presentation to government before, so I'm sure it has been picked up to just negotiate and say, if you are funding us on RAMCA, but we have a shortage in other diseases, how do we move from there, and so on. So in summary, what we have come up with is to show that the commodities, we have a gap in commodities, in HIV commodities, TB commodities, malaria commodities, vaccines, and nutrition commodities. And we have also estimated the gap. And this is the gap in Kenya shillings, in billion Kenya shillings. So if you want to know the dollar equivalent, like I mentioned, you divide by about 130. But more importantly is also the human resources gap, which we said that if the US government through PEPFAR program withdraws 100%, then we will have a budget of about 47 billion, which is supposed to be handled by the subnational level governments. And so this is something which needs to be discussed to see how can we rationalize. Because as I mentioned, some of these diseases have been vertical programs. And so because they are vertical programs, we are likely to be having specific staff just for those diseases. And that's one. Two, in the list, there were also what we call coordinators and things like that. So once we do rationalization, this figure would also be the upper bound. And so we can then agree on a figure for each county to absorb for purposes of sustainability after the withdrawal. Then finally is now what we are making recommendations based on what we have seen in the data, that we recommend the mobilization of domestic resources, especially from public sources, because those are more predictable, and also the fact that it's easier for us to gauge our fiscal space and try to understand how much we are able to put to these diseases. And this can be done when we were advising at that time. It was supposed to be done through supplementary budgets, so that those declines that I mentioned earlier will then be corrected. We also recommended expediting integration of donor-dependent vertical programs such as HIV into routine services to optimize the use of available limited resources. As you know, we do not now want to have a HIV nurse. Let's have a health nurse who can actually handle all diseases. The other recommendation is to facilitate inclusion of commodities for vertical programs into the social health insurance scheme. What is the reasoning here was that the current social health insurance scheme is only covering. Sorry, can you mute, please? So the current social health insurance scheme is only able to cover for the service, but not for the commodity, because the understanding was that the commodities were funded by external sources. But now that the external sources are withdrawing, we need to find a way of how to cover those commodities, of course, to do some budget impact assessment and see how best we are able to fund. So that is a subject which is informed by this analysis. The other recommendation is to leverage private sector solutions. As you know, private sector is one of those sectors that can actually come in handy to both the finance and also provide service at even higher qualities at lower prices. And this ties into the fifth recommendation, which is basically to support the Kenya KEMSA, the purchasing agency, to invoke their what we call supplementary supplies division window to provide affordable and quality health products to private sector that are then could be extended to patients. This is where the KEMSA has a provision that can be used to procure commodities in bulk on behalf of the private sector, what they call the SSD window. And then now the private sector will then source those commodities from KEMSA at a cheaper price and expected to pass the same to patients, as opposed to a smaller private entity importing directly or buying directly. We could utilize this window to reduce the prices. The sixth recommendation is to explore innovative financing approaches. And these ones are listed here for purposes of discussion. It's not like they are prescribed, but we need to find out if there are any additional financing approaches that we can use now that we are faced with a decline in external funding. The other one is to review and increase investment in PHC and community health systems, which will then lower the upstream cost of healthcare, because PHC is basically cost effective, considering that it's cheaper to offer services or prevent diseases before they occur. And lastly, leverage opportunities provided by facility improvement financing. This is one of those innovative acts that were passed in 2023 to allow facilities to be able to retain any revenues that are collected at source, so that to basically do not channel the same to the county revenue fund, which was a requirement in the primary act. So this was to allow facilities to collect and retain, and it extends to the collections that also come from the Social Health Authority, which is the national social health insurance scheme that the country is currently having. So based on all this, of course, this is the wrapping up on what we have done in this analysis, but maybe just quickly to tell you what we are planning to do next, so that I allow you to ask any questions. So one is, we want now to move to the next level, where we will be looking at the impact of this funding, now that we have seen which diseases are affected, which factors are affected, which regions are affected, in more importantly, when it comes to human resource and so on. We want now to use modeling techniques to try and understand how the disease epidemiology will be in these regions and in these diseases. The other thing that we are doing is to look at of course, the epidemiological modeling, as well as looking at access and diagnostics, testing different diseases and what it means for the health outcomes and of the individuals. And the last bit is what we are doing is to do what we call computable general equilibrium, trying to understand how the impacts that we have witnessed in the health sector will then translate to the impact in the other sectors in the economy. And that will be phase 2. Otherwise, what we have done is what I've presented today. So thank you very much, and open for any questions.
Thank you. Thank you so much, Dr. Khaoya, for the session. It was really informative. So we enter the Q&A session. Continue posting your questions on the chat, or you can raise your hand also if you have any question and ask. I think we'll jump into the first one asked by Alan. So Alan asked, great work, Dr. Khaoya. May be useful as you perhaps refine the report is to indicate the sources of your data in various slides. For instance, off-budget sources of funding have been notoriously difficult to estimate. What's the source?
Okay. Yeah, thank you very much. I think in the report we have put all the sources, and like I mentioned at the beginning, we have we relied on the what we call donor reports, as well as information that we gathered directly from the donor. So in the report, you will see clearly where we have gotten all the reporting, the data, and we have adequately highlighted where we got that and what we have done with that data. But thank you for raising that.
Okay. The next one is from Dr. Paul Carril. For the human resource gaps that would need to be covered in the various counties, are these computed using national payment rates, or would this be payment rates as provided by external funders?
Okay. Yeah, so what we did was basically to use government rates. The only information we used from the funders is who are they supporting in terms of cadre. So for example, if they say they are supporting 89 staff, the most important information was to know how many of those are doctors, how many are nurses, and how many lab technicians, how many are epidemiologists, and so on. So we use that information to convert the numbers into the monetary value. And so part of what the challenge was, like I mentioned, was you get a list of cadres that are not within the government scheme. And so how do you, for example, convert the mentor mother into a monetary value, and yet mentor mother is not within the government scheme of service? And those were some of the challenges we had, but we did that using the government rates. Thank you.
Okay. The other question is from Alfonso Yugi. Good presentation. My question is on overfunding for RAMCA programs. What is the perspective of the donors on this? Is it a question of equity based on the need for various programs rather than equality, or donor interest area of focus?
Yeah, thank you very much. That's a very valid question, because it's something which we have identified in the course of the analysis, that diseases like RAMCA or programs like RAMCA are actually appearing to be overfunded. We cannot blame the donor, because when you go, or when the donor interacts with the government, they basically are supposed to be guided by the priorities of government. So if one of the priorities could have been RAMCA programs, they have actually put in resources to be able to support RAMCA program. So if the funding ends up to be excess, it requires discussion, because this could be dedicated support where the donor says, I'm willing to support you on RAMCA. So they don't expect you to now redirect those funds to HIV or other diseases. So there's need for further discussion, for agreement in terms of where do you redirect those funds, and how much of those funds do you redirect. One other thing that sometimes is a big challenge is the donor says, I'm putting in $100, and for every $100 I put in, you put in 20. So you end up with 120, and maybe the requirement was 90, and so on. So you end up with an. So it calls for a mutual understanding and a mutual agreement of how do we redirect those funds, because clearly what we have seen is that we have gaps in other diseases, but we have an excess in one of the programs. Thank you.
All right. Sorry. So the other one is from Mera Shah. Given that it has been nearly a year after the USAID suspension for health, to what extent has Kenya taken up the financing of these health investments, e.g., HRH, health commodities, etc.? Thank you.
Yeah, thank you. That's a very valid question, because we are looking at a period of the last 1 year. So anybody will be interested to know what the government has done. So I may not have the details, specific details, but what I know is that we've witnessed a situation where the government has increased. One, the counties have taken up some of the stuff. There was serious negotiation to agree on the numbers. So what I present here as 41,000 staff actually was discussed and agreed at about 11,000. So those 11,000 have been prioritized for absorption, and the county government has absorbed some of them. But like I mentioned, the county government is not obligated to absorb all of them, because some of them have also had other initiatives such as integration. So instead of now having a HIV dedicated clinic with a HIV doctor, HIV nurse, HIV whatever, now they are saying, look, we can take 2, but then we provide those HIV services alongside the other services. So there are many, and if you, for those of you who are in the country around the time of the withdrawal, we had a lot of memos running around from the leadership to the people in the front facilities to actually guide them on what they need to do in terms of integrating, in terms of maybe task shifting, and so on. So all that effort has been there. But important again is about what the national government has done to try and also absorb some of the stuff. Many of you have been aware of some of the discussions that have been going on to absorb some of the stuff that had been given contracts and now need to be absorbed on a slightly longer term basis. Over.
Okay, thank you. And I think Anne's question on the same has been answered. I hope that's clear, Anne. So the next question is by Jeanette Dawa. More of a comment, and maybe you can reflect on it, Dr. Khaoya. Regarding remedial measures, I would be cautious on promising integration of vertical programs into routine services. What is the performance of routine services for hypertension, diabetes, etc.? Performance is not good. Performance is not good. Won't we see a decline in performance of HIV indicators by integrating them into a poorly functioning routine service for other chronic diseases? We cannot fully do away with a HIV nurse with specialization comes improved performance. Perhaps we should seek a rationalization of the total staff required to provide HIV care in a county rather than integrate HIV into routine care when routine care is underperforming. And Anne, we will come back to your question.
Yeah, and that's a very good reflection. So I think this is what calls for a discussion to know what is it you can integrate. Because when we talk about integration, there are many things you can integrate. You can integrate at many different levels. For example, you can integrate supply chain. Instead of having a truck transporting ARV commodities only, you can have the same truck transport other commodities alongside. Instead of having IT systems that only focus on HIV, you can have an information system that is all-inclusive. And so integration is not just about at the service point. You can integrate at the different building blocks. And through that, you can then save some resources to be able now to say, okay, because of all these savings, we can now maintain the HIV nurse or the HIV clinical officer and so on. And then, of course, issues around looking at it in phases so that you are not stopping today and telling HIV nurses and HIV clinical officers to exit. But then you say how best, because integration is not about letting the HIV ones leave. It's about having an amicable solution that brings everybody together so that we serve the patient as a whole and not just serving the disease. And so I agree with you. And that is actually, I will also request members to tune in, because we expect now when we do our second analysis, we will now be showing exactly what are these health indicators for these disease programs that we have identified. How are they progressing over time, especially after the funding cuts? And so part of what we'll be coming with you next with you is to discuss exactly that. So thank you for those reflections.
Okay, and to Ankyo's question, good presentation, and thank you very much, Dr. Khaoya. What will be the implication of the Kenya-US health deal signed in December if it is implemented?
Thank you. In fact, you've reminded me, because part of what is being discussed, if you go to that cooperative agreement, is basically focusing on these factor inputs, like the commitments on commodities, commitments on human resources, commitments on infrastructure support, commitments on disease surveillance, and so on. They're actually being informed by this type of analysis, because I know we've discussed with the ministry at different points just to understand what was the extent of support when it comes to commodities, what was the extent of support when it comes to human resources, and so on. So if you read the cooperative agreement, is basically trying to focus on those areas that were supported in the using external funds. And so what is happening is that now that cooperative agreement is institutionalizing that support, so that we do not now rely on uncertainty, but we are certain that come next year, there will be some funding for commodities. There will be some funding for human resources. There will be some funding for to support infrastructure and so on. So I think to me is a good approach. It's just that people are discussing the technicalities. So the amounts and the areas of support are already known. So the technicalities in terms of, okay, who handles what and what do you get in return, those to me are issues that are being discussed. And once they are cleared, everything should be okay.
We are running out of time, but we have some questions we can, maybe Dr. Khaoya, you can address quickly. One from Dennis Osiemo. Did you distinguish the RAMCA funding between RH and MCH funds? Perhaps the overfunding is on RH and not MCH funding.
Yeah, no, unfortunately, we didn't go into the details of exactly which particular branch of RAMCA is being overfunded and so on. I think that is something we can go back to the budget and try to see which programs are these that are funded. Are they MCH? Are they reproductive and so on? So as at now, no. So, but that information is available.
Okay, Robinson Kahutu has asked the KHFS implementation primarily, sorry about that. KHFS implementation primarily involves domestic resources and considers donor resources at the periphery. Does the analysis indicate any progression towards shedding out dependence on donor resources?
No, what we have done in the analysis is to give a snapshot of what we see in the budget. So I know the Kenya Health Financing Strategy in terms of like what it prioritizes is domestic funding. And if you look at it also, there are quite a number of recommendations in that strategy, including the social health insurance scheme, which is something which is also clearly envisaged in the strategy. So for our purpose, it was to give a snapshot. But the Kenya Health Financing Strategy, of course, has recommendations, part of which have been implemented now, including the social health insurance scheme. So I think that's all I can say, because this analysis was not about showing who has prioritized what, but what the picture is in the funding landscape. Over.
Okay. And Lucy Mithu is saying, thank you for the insightful presentation. Do we anticipate increase of OOP spend with transition to domestic funding in future, e.g. on commodities and services like labs?
Yeah, so the out-of-pocket spending normally is driven by many factors. Sometimes even countries that have implemented a social health insurance mechanism have ended up reporting very high out-of-pocket spending, especially not because of other reasons, but the reasons to do with the timing. If it takes time, for example, to reimburse a facility can easily ask people to start paying. So while you are reporting social health insurance reimbursement, you're also reporting high out-of-pocket spending. So in the immediate term, and for those who are doing an analysis of out-of-pocket spending and how it's impacted with the current reforms, you should be aware that if you get out-of-pocket spending going up, you should not be surprised. It has happened in other countries, and it will be something which is in aligning with what we have seen in other countries. But thank you for that question.
Okay, and a comment from George. Remember, there's introduction of new drug, lenacapavir, a game changer to HIV treatment and management, and I think he is asking for your thoughts on implication this may have in terms of HIV funding.
Yeah, so any innovative approach to either coming up with a cost-effective drug or coming up with something that will reduce cost is always good. And what we are looking forward to is if there is a drug that maybe leads to a unit production of that service coming down, that will be good enough. So I've not personally, because I'm not technical in that area, I've not looked at exactly that particular drug, but my colleagues at CEMA are doing quite a number of studies to show the cost effectiveness of introducing new drugs, and that will be part of what we can consider. Over.
Okay, and then a last one from Dorcas. Yes. Do we have goodwill towards the Maputo Protocol funding commitments with the existing cooperative agreement?
Come again, goodwill towards what?
Towards the Maputo Protocol funding commitments. And then she goes with the existing cooperative agreement. Do you need her to clarify further?
Yeah, maybe I'm not very conversant with the Maputo agreement, but what I know is that the current cooperative agreement, especially between the US government and the Kenya government, is basically institutionalizing what has been there. As you know, they are just trying to say, okay, we've been funding you through implementing partners. Can we have an agreement where we fund you directly? So that because they have realized that maybe implementing partner costs are eating into the support. And so they want to see, can we have that support come directly to government? And for them to do that, of course, they need to be an agreement that when I give you this money, this is what you will do. And that is very normal with anybody who is supporting you, who wants to know whether you are fulfilling your side of the bargain. And the government has also come in very strongly to say, okay, this will be fulfilled, but this other one is difficult to fulfill and so on. And that's why it's now being a subject of public participation so that everybody is comfortable with what is being agreed. But I'll be happy to get to the Maputo agreement and see exactly what is there for purposes of seeing how it affects us. Over.
Thank you. And I think with that, we end the Q&A session, and a big thank you to Dr. Khaoya for the sobering and essential analysis. I think it's very clear that while the withdrawal of external funding presents a massive challenge to our health programs, it also serves as a definitive call for Kenya to accelerate its path towards domestic health financing. That is, even with the G2G arrangements that are currently in place. To our audience, thank you for your engaging questions. This conversation is vital for the policy shift we must advocate for to ensure our health system remains resilient. So the recording of this session will be available on our YouTube channel. The recording of today's channel will be available on our YouTube channel, and the report will be also available later on. So keep checking our socials. We'll be updating. Thank you for joining us today, and have a nice rest of the week.
Thank you very much, everyone.
Thank you.
All right.